it's not good then to just use it temporarily
No.
for a year to lose weight for that wedding, etc., because you could just gain it back. Hi, this is Dr. Din, board certified dermatologist. I'm so excited to welcome you to our very first podcast. We are going to be diving into the world of GLP-1s, a very, very relevant topic, trending everywhere, TikTok, Instagram, Facebook, whatever it is that you use. And we'll be reviewing what that is, how the medication works, what it's used for, as well as what are some things that you can do to try to minimize some of the side effects with that medication. I'm joined here today with Dr. Lindsay Van Dyke.
Hello.
Welcome. She is double board certified in internal medicine and endocrinology. She is owner of Advanced Institute for Diabetes and Endocrinology in Texas. She is an author, cancer survivor, and my dear friend. I'm so excited that you're here.
I'm so excited to be here.
We're going to be doing a two-part series. So part one, we'll basically dive into some of the questions that I have. And then part two, we'll go over more of that side effects and what patients can do to minimize it, as well as the frequently asked questions for our patients.
Okay, let's do it.
So let's just start this simple for our listeners. What exactly are GLP-1 medications? How are they used? And what are they prescribed for?
GLP, which is shorthand for glucagon-like peptide type 1, are a class of meds that have been around for a little over 2 decades now, primarily in the diabetes space. And in the last probably 5-6 years or so, they've begun to expand into weight loss and other kind of metabolic associated conditions like fatty liver, sleep apnea, and so on.
So we're seeing that, patients are being prescribed this medication for these diseases that you're mentioning, but now they're also being used off-label. Is that correct? Off-label for weight loss?
No, it's on-label.
Oh,
actually.
on-label.
FDA
Okay.
has approved 2 agents for that. Yeah.
So why are we seeing this explode on the internet, in celebrities, in everybody's circle of
why
family?
now? Yeah, probably the first weight loss GLP was actually Saxenda, and that's been some time ago now. And then Ozempic, which was for diabetes, got rebranded as Wegovy for weight, and that was about 2019. And then Mounjaro came on scene for diabetes and was rebranded as Zepbound for weight a year or 2 later. So why did it hit a tipping point all of a sudden? I don't know, except that the internet is a wild and crazy place.
And I agree. I also think that celebrities are using them, and some of these celebrities are not even obese, but they're using them for weight loss for many different reasons. But at the same time, we're also seeing that when people are using them, they're also losing fat and muscle. So how does that work, and what are your thoughts on that?
So it doesn't matter how you're losing weight, whether you are on an intensive lifestyle regimen, like on Biggest Loser, or you're using medications like these, or you're having a bariatric surgery. Up to 35% of the weight that's lost can be lean mass. And that's a problem because your muscle is your largest metabolic organ. And so I tell patients, I don't want you losing weight. I want you losing fat. The muscle we want to keep, because that is how we age well and remain functional.
So what are some ways that patients can prevent or decrease that risk of losing muscle?
It underscores the need for a very comprehensive, sometimes multidisciplinary plan. It's a great disservice to patients who are needing to lose weight for there to be kind of an internet pop-up online form to fill out to get your med delivered to your house, and then they just kind of like, okay, go forth in the world and lose weight. Obesity and metabolism, they're very complex problems, and the landscape of the metabolism evolves with time. It evolves with how much muscle you gain or lose. It involves how much fat you've gained or lost, your dietary components, which doses of meds you're on, and so on. So it deserves consistent follow-up and guidance, because it can be very frustrating if you stall and you can't figure out why.
So when you, let's say, write a prescription for a patient to start these medications, are you going over how much protein intake they should be doing while on the medication? And how do you determine how much protein that patient needs to be ingesting?
Absolutely. We only do comprehensive weight management. I never just say, sure, take this med and I'll see you in 6 months. So we like to use the body composition analysis to know how much lean mass we have in someone. I tell them, we need to find out what you're made of, And once we know what you're made of, we can make meaningful decisions about what we should do with the calorie load, with the protein target, and so on. And the general principle, I'll give my body composition as an example. I did one just a couple weeks ago, and it said I carried about 95 pounds of lean mass. So in general, outside of kidney disease, our principle is 1 gram per pound of lean mass per day. So 95 grams is a lot of protein to take in, and that's very hard to do just with whole food eating. And so this is where we use more lifestyle coaching and dietary guidance and that kind of stuff on intervals with composition analyses to follow how people's bodies are changing through the process.
What does it look like to eat 95 grams of protein? Is that like 4 chicken breasts a day, 5 pieces of turkey legs, or what is that?
Yeah, it's a lot of food. Mm-hmm. So when you're talking about weight loss, you talk about a toolbox, right? Medication is one tool in the box. Dietary counseling is another tool in the box. Exercise is a tool in the box. Protein concentrated forms are another tool in the box. So I'm fond particularly of protein shake because it's something I like to do for breakfast. It's easy. It tastes good. I kind of nurse on my protein shake all morning. And I know when I'm done with that I've got between 30 and 40 grams already in my day. And I can hit the rest of my targets with my lunch and dinner. And not all protein shakes are created equal. Some taste terrible. Some are gritty. Some do or don't have multivitamins in them. So we're very specific about the kind of protein shakes that we recommend.
Which ones do you guys tend to recommend?
We carry a brand in our office called Cornerstone, and it's got the multivitamin built into it. The formula is really excellent. It's a whey-based protein, so very nutritionally replete. It's smooth and creamy. There's no grit. There's no weird aftertaste or anything. And the flavor is not very intense. So it's going to take on whatever you are mixing into it, which I think helps people with a lot of flexibility because no one's going to eat and drink the same thing every day for the rest of their lives.
Yeah, exactly. What about the patients that don't want this is a whey protein?
This is a whey-based, yeah.
So funny because like in dermatology, whey protein, if you take a lot of that, it can actually cause acne. And so I sometimes educate my patients about, okay, are you doing any whey protein supplements? If not, you got to switch it. Is there like a pea protein alternative that you can recommend in case our patients get acne?
Yeah, it's harder to do it in, let's say, a vegan recipe. The one that I'd say is most popular is called Kachava.
Okay, yeah. Very good. You guys heard that? That's another alternative brand for you to use. So patients are losing fat. We don't want them to lose muscle, right. Hence the protein intake. And then I'm assuming lifestyle changes like exercise.
Oh, yes. You can't do this without exercise. That is fundamentally part of the metabolic plan. If you are not doing exercise, your brain is going to decide that you don't need that stuff around. You don't need to maintain that stuff. So it's going to start offloading your lean mass. And that's a problem for you. It produces plateaus. It frustrates people. Why? I haven't changed anything. Why am I not losing weight anymore? Because your body got smarter.
And what kind of exercise do you tend to recommend for our patients?
So I deal with a lot of populations that are somewhat sick, or mobility is an issue. So it's very complicated. What works for me might not work for you, might not work for this guy down the hall. But what matters the most is the strength. And we're not talking about Lifting, casually, okay, I got my 10 pounds, I'm going to do 15 reps, and I'm going to do 3 sets of that. No, you are lifting to exhaustion, because that is what it takes to make the body build new muscle fibers.
And when you do advise these patients these lifestyle choices, do you also talk to them about how much weight they should be losing per week?
Oh, yes. Yes. We live in an instant gratification society. Somebody wants to start meds today because they got a wedding to be at in 3 months and they want to be 20 pounds lighter or something. And it doesn't work that way. Not everybody responds to these meds the same way. And so you, for example, might give you just a little whiff of a dose and you might just start dropping weight like crazy. And the guy next to you might require the highest dose in order to get some kind of change that he feels is meaningful. So everybody is different. But in general, that old gold standard of 1 to 2 pounds per week is what we're still after.
So essentially, when these patients are losing 20, 30, 40, 50 in a very quick amount of time, not 1 to 2 pounds a week, some patients are losing more than that, right? Are you seeing that too?
Yeah.
That's when that quick weight loss can be detrimental and be problematic, like what you said, because they're essentially starving themselves.
Kind of, yeah. And these are powerful meds, make no mistake. And it is easy to just shut off the appetite. And that's not okay. That's not normal. You are supposed to have hunger and satiety throughout the day. If you are nutritionally deficient or you are dropping weight too quickly, it really triggers panic mode in the brain. So I advise people, you got to think about the equipment that you've been issued. And you were issued a body that's designed to be maximally efficient under starvation conditions. It reached its peak, a few 100,000 years ago, and it still thinks it's that time today. It doesn't understand that there's bariatric surgery or tirzepatide or Weight Watchers around. So, in fact, I think we should talk about how this mechanism works. The part of your brain that regulates energy balance is located in the most primitive portions, in the hypothalamus, that reptilian part of the brain. It's very sensitive to changes that are happening around it, but it is not smart. It does not know what you weigh right now, and it does not know that you might be doing this on purpose. So there are a few ways you trigger panic mode in the brain. One of them is by losing weight too quickly. One of them is by losing a threshold amount of weight, approximately 20 pounds. And another way is by being nutritionally deficient. Any of these things happen and ears go up on your brain. It's like, oh my God, if this keeps up, we're going to die. We got to put the brakes on this. This is no good. So what does it do? It wants to lower your core temperature. It wants to reduce your heart rate. It wants to demotivate your brain. So all you want to do is be a lizard laying around on a hot rock. And then it's going to preferentially try to offload expensive tissue. What is that? That is your muscle. So as your muscle mass dwindles, so does your daily metabolic rate. So if you've been doing your lifestyle, taking your medicine, you've lost weight and so on, and it stops, you haven't changed a thing, well, guess what? The playing field is different now. It got smarter because it doesn't want you to die.
You make such a great point. You're absolutely right. When patients are losing this amount of like a large amount of weight in a very short period of time, basically stresses out the body.
Yeah.
And we see this reflected in dermatology, because then they're coming into my office saying, I lost weight, a lot of weight, 20, 30 pounds in this short period of time, and now my hair is falling off.
Yes.
And it's shedding like crazy, like clumps.
Your brain
and
doesn't have time for hair.
Exactly.
Get rid of the hair.
It's trying to just preserve your life.
Yes.
Like the hair is like a secondary thing. So this is called telogen effluvium. We see it in postpartum patients. We see it in patients who go through severe illness, like anything that stresses the body, such as weight loss, like in this way. you're going to see that hair loss. And we saw it a lot with COVID too. And it can last. It can last anywhere from 6 months, even up to a year. Or if your body's just continuously stressed for whatever reason, you're going to just keep shedding. It is temporary though. So once you stabilize and that stress level goes down, the hair does come back, but it takes time. And I think it depends on how well your body's adapting to this new normal. I'm also seeing a lot of changes in the skin because a lot of these patients are coming in, they're very dehydrated.
Yes.
Their skin is dull, no longer firm. And because they've lost muscle and fat, the face is gaunt and hollow. And my patients will say, look, I've lost X amount of weight. I feel great on the inside. But when I look in the mirror, I feel like I've aged 10 years. What can I do? What can I do? You know, this is going to be very patient dependent on my advice to them. I usually say, if you're still losing weight and you want to continue losing weight, then you really need to make sure your skincare is being, you're using something that's helping to build collagen. So that's like using a retinoid, whether it be over-the-counter retinol or a prescription strength retinoid. Now, these are not miracle drugs where you're like, oh, now I put it on, my face is back to normal. It's going to build collagen over time. You can also incorporate some procedures like microneedling, maybe monopolar radio frequency, just things that can stimulate collagen underneath the skin. Now, in terms of the fat loss, I can't make you build that back. There are things that you can inject into the skin to get to that volume loss. That's like filler, fat transfer, maybe some biostimulators to try to help produce that collagen there.
Because there's no way to pinpoint fat loss. It's
Yes.
diffuse loss everywhere, and you tend to see it first in the face.
Yes, which is unfortunate, but the reality. And I wish someone would invent like something where you only lose fat in this specific area.
Yes, that'd be nice.
Stomach and butt or whatever, but no, like you lose it everywhere, including your face. You lose it in the arms, which is what you like. But however, when it's fast, they get very flabby skin there. And I'll give these recommendations for some procedures, but ultimately the really severe sagging, I usually say surgery.
Yeah.
You might need to make a consultation with the plastic surgeon.
Yeah. It's like you need a multidisciplinary team in place. You have your obesity or endocrinology specialist, you've got your derm, maybe you got plastics sitting on the standby.
Exactly. Exactly.
You got physical therapy to keep you buff.
Yes, absolutely. Absolutely. So when you talk about this muscle loss, which is very big, we know that that's a very big deal for women.
Yeah.
When we're in our 40s, 50s, we're going through these hormonal changes. We're already losing muscle to some degree because of the hormonal shifts. What's your advice?
Such garbage.
What's your advice about that?
Oh, yeah. It's unfortunate that it's called sarcopenia, this kind of age-related wasting of muscle fibers. So the fibers get thinner and then there are fewer of them. And remember, that's our metabolism. So starting in our 30s, that's going to begin to waste away our caloric expenditure. And then what happens as lean mass comes down, fat mass begins to creep. You get away with this for a while. You will get to kind of a tipping point where you're like, what the heck, man? I haven't changed anything. Now I look totally different and I'm mad about it. And it didn't happen overnight. It happened gradually until there was this threshold awareness about it.
Do you find that your women patients who are going through these hormonal changes, are they losing more fat while being on the GLPs versus the men? Have you seen a difference? Or more muscle and fat.
Oh, more muscle.
Yeah.
How much muscle someone loses, I think, is just so dependent on, are they feeding their muscle? They're getting adequate protein intake, and then they are using that muscle to build. Men seem to hang on to more muscle a little easier than women do in general. But statistically, there doesn't appear to be a difference between the sexes through the menopause years in terms of who kind of balloons with more fat and more muscle loss. But if someone is not working intensely enough with their strength regimen or their physical activity and so on, then they're just not going to, they're going to have a slower time of losing. They're going to be more frustrated by their measurements too, because that's where the money is. The money's in the measurements. I don't really care what the scale says. Muscle's heavy. You could have a scale that doesn't change that much. But if you're building a lot of lean mass, your measurements are going to go whoosh.
I see. When you start patients on the GLP-1s, do you do lab work beforehand? Are you monitoring anything throughout this whole time?
So when we do a new consult for comprehensive weight management, because that's all we do. We never just kind of say, here, have a med and turn you loose on the world. Maybe we'll see you in a year. This takes guidance. It takes deliberation. It takes time. I am looking for all kinds of underlying factors that are potentiating fat gain. And there's a number of endocrine tests and things that we're doing. And in part because if you want insurance to cover these things, then there's an art to finding the right diagnosis. If you find liver dysfunction, if you find active coronary disease, if you find diabetes, prediabetes, all that stuff stacks up in favor of getting a policy to pay for the med. And so I do a boatload of labs at the front end. And then in terms of surveillance, there's no real active guideline about what should be followed. If you find liver dysfunction, yes, you should follow it. If you find a nutritional anemia, yes, you should follow it. But other than that, it's very kind of patient dependent.
And I think this goes on to really emphasize the monitoring aspect in terms of following up with the patient when they do start a medication like this, because you never know what their diet is going to be like. If they're not eating enough macro and micronutrients where they become deficient in something, they'll never know that until they see the doctor or PA, whoever is prescribing it. And they're like, there's something off about this. Maybe you're developing some symptoms that could be a sign of something and needs to be worked up. And you're right. When patients are just giving a prescription and they're told, okay, well, good luck, we'll see you in a year, they could be developing something later and not know that.
You don't know it. Yeah. Silent.
Yes. It's interesting because there's so many websites online that will prescribe you this medication. Not sure who's doing it, but it's very easy to get.
There are mills all over the place. Yeah.
So I'd like to, before we do our rapid fire, ask this one last question. What happens when you stop the GLP-1? Will the patient gain the weight back?
So this is a chronic condition, and we need to think of it in the context of other chronic conditions. If you've got high blood pressure and you give a med and you improve it, then you take the med away, what happens? It goes back to baseline. High cholesterol, treat it, gets better, take the med away, there it goes. Weight is the same thing. We are altering metabolic processes here. And then the brain is thinking, okay, I need to do something about this. So it's altering metabolic processes. So if we have you on therapy and you've gotten to your goal and you're pleased with it, and okay, let's go into maintenance mode. I guess I can stop the med. We expect that you're going to go back to a baseline. But because your brain is the wild card, it's gotten more efficient, you'd actually fall back beyond your baseline.
So you're saying gain the weight back, yes.
Yeah.
And perhaps even gain more than you originally started with.
It's a common phenomenon, yes. So what we see in the literature, in longitudinal studies, that about 2/3 to 3/4 of patients who stop the meds will gain the majority of the weight that they lost initially in the first 6 or so month period. So it's pretty impressive regains. And every once in a while I get a patient who has to come off the med for one reason or another. Their insurance won't cover it anymore, or they didn't feel good on it, and they went to the hospital and they said, okay, stop the med. And they come back to the office, they're very distressed because the regain is already happening.
Wow. So it's not good then to just use it temporarily for a year to lose weight for that wedding, etc., because you could just gain it back.
We always talk about medical management of obesity as a lifelong decision. We may modify dosing structure, we may modify amounts or intervals that we take them, but it almost always is going to need to be continued.
Interesting. Are you hearing that, everybody?
Yeah.
You can't just take it for like 6 months, 8 months to look good for whatever event, because if you do, you will probably lose the weight, but you'll probably gain it back. That's pretty disheartening. So thank you, Dr. Lindsay Van Dyke, for being here. That concludes our part 1 session. Stay tuned for part 2, where we answer your questions about GLP-1s. If you enjoyed today's episode, please subscribe, leave a review, and share the podcast with someone who might find it helpful. This podcast is intended for educational and informational purposes only. It is not meant to replace medical advice, diagnosis, or treatment from your own healthcare provider. For additional science-based dermatology information, visit aad.org. To learn more about our dermatology practice, visit www.dindermatology.com.